name's Kim Hooper. I'm an osteopathic physician. I specialize in family medicine. I have a special interest in osteopathic manipulation and manual medicine. Osteopathic medicine is a system of medical therapeutics that involves conventional medical treatment and diagnostics, but it has a special focus on the neuromusculoskeletal system, and that takes the form of a type of manual medicine called osteopathic manipulation. I do manual therapy in the form of osteopathic manipulative therapy on a daily basis. I often give patients home physical therapy exercises, and I often refer patients for formal physical therapy evaluations by physical therapists. Well, as a family physician, it's hard to say who my typical patient is. I mean, I take care of people who have diabetes and high blood pressure and a myriad of other types of diagnoses. But I do have a special interest in people who have musculoskeletal problems, low back pain especially. And so I frequently utilize physical therapy and manual therapy, and as I mentioned, refer patients to physical therapists. A lot of my patients have surgery, and especially when they have orthopedic surgery, that often, if not usually, involves some kind of physical therapy after surgery. And usually I'm helping coordinate that, or I see them post-surgically to check their wounds, or many times they have medical problems that need to be managed as well. Sometimes people have surgery and their post-surgical course is very smooth, everything went fine, and they don't have much pain. But sometimes they have a lot of pain, and sometimes they have complications. And sometimes those complications become chronic complications. It doesn't happen very often, but occasionally people get post-surgical infections, and then that can lead to months of problems. Or they have wound breakdown, and then they have to have treatment for that. And so many times they're on pain medicines, including opiates, for longer than we would like. And then we have to start some kind of program to gradually get them off of opiates and substitute other therapies. You can be physically dependent and not be addicted. And so that's just a matter of kind of weaning people down, but many times they'll continue to have pain. And so finding other methods to treat their pain is important. These days especially, we physicians have kind of a heightened awareness of opioid use and addiction problems in general. And so there's a number of methods we use to monitor our patients' use. In fact, our patients' use is monitored not just by us, but it's monitored by the pharmacy where they get their medicines, it's monitored by insurance companies that pay for the medicines, etc. So we do a special online search of where patients are filling their medicines. That's called an ORS search. And then we also we're required to do periodic drug screenings for patients who are on chronic opioids. And then we also ask specific questions that try to get at that. Patients who are the most likely to become dependent on opioids are patients who have a complicated course in their post-surgical course, who have poor social supports, and who have underlying psychological issues. And so assessing those kinds of things, those issues, also helps us to get an idea of who might have problems. So if somebody has become opioid dependent and it is time to start weaning them down, some of the strategies I use are the following. I try to establish a good therapeutic alliance with the patient. And that usually means good communication, close follow-up, having a joint plan that I formulate with the patient so that it doesn't feel like they're being dictated to. And then we gradually use a stepwise fashion of lowering their medicine very slowly and establishing expectations that they're not going to be pain-free, but hopefully their pain will be manageable. And then we start bringing in non-pharmacologic methods of treatment. And those include a wide variety of things, from heat and cold to traction to manual therapy and physical therapy. There are certain kinds of pharmacologic means, such as non-steroidal anti-inflammatories. There are topical medicines. So there's a bunch of topicals. Diclofenac, which is an NSAID, is topical, and then topical lidocaine, topical, sometimes just counter irritants like Icy Hot. We utilize a broad variety of things. There's also other types of medicines that aren't opioids, such as antidepressant medicines and a class called SNRIs, and then there's another class called neuromodulators. And none of those are really addictive, and so we can start to use those medicines and they can help take the place of the opioids. When you have a pain generator, say your low back, and then that pain is transmitted up the spinal cord, so you can intervene in pain where it's generated in the low back. You can intervene at the level of the spinal cord, and then you can intervene where the pain is perceived in the brain. And then there's an emotional component that the pain tends to stimulate. So, you can have pain and then that can start to make you feel bad, and then you can feel worried and anxious. Is this pain ever going to go away? And so you can also intervene in that area too, because if you have that kind of emotional overlay, it worsens the pain. So the same pain in someone who's not depressed is perceived as worse in somebody who is depressed, for example. If you assess somebody's risk for opioid abuse, and there are questionnaires we give people to try to do that, and it has to do with, have they had problems in the past? How have they responded to pain in the past? Do they have underlying psychological issues or worries about pain? And then partly about their social support. Do they live with somebody who is a loved one who helps support them, or do they live alone? And people who live alone have more worries and problems in their life. They're more prone to having difficulty with pain. I have a patient, a young woman, who had a ruptured disc in her neck and had a lot of pain in her arm. Because of that constant pain, she had surgery. And afterwards, she continued to have some pain and was maintained on opioids, which she was on before the surgery, and then she reduced them but couldn't get off completely. However, as months and years went by, she got better, and she wanted to come off her medicine. And she was using a fentanyl patch as well as a PRN opioid. And so we very slowly started weaning her off. And typically people who are on an opioid dose are anxious and are afraid of reducing their dose, because typically what happens when you reduce a dose is you have more pain. You kind of have a little rebound pain, because the receptors that are used to a certain opioid dose will become more sensitive once you reduce the dose. And for a couple of weeks, they'll have more pain, and they think this is what it's like if I don't take this much opioid. But really, it's sort of a rebound sensitivity of their receptors. And if you can get them through that, then it settles down and they get kind of to a new level where they're okay. And then you reduce their dose again and they have a little bit of a rebound, but if they get used to that and you talk them through it and you collaborate with them on how to deal with it, and you also give them other strategies to deal with the pain, and that can include some of the things I mentioned, physical measures, heat and cold, counter irritants. I do manual therapy on them. Sometimes I send them to physical therapists, and that's all very helpful, and it helps support them and get them through and give them other strategies to deal with the pain. And we were successful at getting this person off fentanyl. And so she's managed on a fairly low dose of pain medicines now.